It's my pleasure today to announce and host yet another LTSI Masterclass with the help of our President, Dr. Sanjeev, Dr. Charles, our Secretary, and Dr. Abhideep, who have started all these things together. And we are seeing it happening again today. And today's topic, very interesting, the concept of reversibility in ACLF. So, do definitions matter? We go by books, but we are going to learn from practical experiences. And as Dr. Raki mentioned, that how we should do in our cases, and everybody has a different practice. We'll discuss a little bit. I would like to invite Dr. Sanjeev Saigal, our president, to invite our esteemed ILBS team.
Thank you, Naveen. It is really a sense of great, delight for me to welcome you all to this extremely insightful masterclass. This masterclass concept, which we have started as a part of LTSI initiative, I'm sure has taken up quite interestingly. We are going to clinical part, pathology, radiology. So we're trying to cover as much as possible. And I must extend my deep gratitude and thanks to the ILPS team led by Professor Sareen and then Rakhi, Ashok, and everybody who are here today to conduct this masterclass and give us a thought, an idea of treating, ACLF, which is the most hot topic these days. So that part is, I think, something really we are looking forward to. But I really would like to thank you all for joining today, and I'm sure that this masterclass series will keep on, increasing further, and maybe we'll have more refined processes later, subsequently, and get it into more, structured way. And I would hand it over to Dr. Ashok Chaudhary to take it over from here and introduce the speakers and the format of the masterclass today. Dr. Ashok, please.
Yeah, thanks. At the outset, I thank the team LTSI to ACLF to do master classes. And the team till now. And
Dr. Shishir, can you please
Dr.
mute yourself?
Shishir, please could you mute? Yeah.
So it is part of the ACLF field controversy is the definition. And what, as far as concerned, this ACLF definition concerned for the East and West, the whole Eastern part, the Apostle has shown a big lead in this field under dynamic leadership of Professor Sareen. We are able to gather evidences, largest database, and with this, I think we have operated the latest ACLF consensus, the Kyoto Consensus 2025, and which is one of the you can say mammoth task to make people across all the definitions, ASLD, ASL, COS, ALE, CLIF, all being sitting together to be part of this to come with formulations to make it a type A and type B. And after this type A, type B, now all definitions considering the reversibility, regression, recompensation has come up. So these are making a big way as far as the definition is concerned. So today, I think we are going to cover on this. So Professor Rakhi is going to talk her area of interest is plasmapheresis and AKI and sepsis also, and her highest quoted that alcohol and ARC score. So this is one of the few interesting areas in this. And then we have two young, bright, dynamic and emerging faculties of the ILBS family. So Dr. Omkar and Dr. Daniel Jaifrin, they are going to have a case-based discussion, and after that, Professor Sareen is going to summarize what is new and how our practice is going to change after this ACLF Kyoto consensus. So I request all who are here or those who are going to heard in the recorded YouTube video for this LTSA consensus, they can able to get a good view as far as concerned is this Apostle consensus. And I request that, I think I just had a word in the morning with Professor Sareen, that the Kyoto consensus has been cited till now very less number in compared to Apostle ACLF consensus. So this is because the initially it comes as the Apostle consensus, but now it is coming as Kyoto definition, Kyoto consensus. That's why people is not getting linked. But hopefully our hepatology community, once they make it citation for the Kyoto consensus, the things will come as APASL 2025 consensus. We thought of that it is going to beyond the Asia to the global. So hence the name was Kyoto consensus. So we request that all ACLF definition and presentations and publications should cite this Kyoto definition or the manuscript. That will be good reward to. I think most of people are here are also the part of that consensus. So I think that way we can have a good visibility on the ACLF definition. And with this, I request Professor Rakhi Madam to carry over the next session. Thank you, ma'am.
Thank you, Dr. Ashok. Dr. Rakhi, you're muted. Yeah,
Yeah,
thank you.
sorry. Thank you, Ashok, and thank you, LTSI, uh, Dr. Sanjeev sir, and everybody, Dr. Abhideep and Naveen, for giving us an opportunity. So what we have planned is to discuss. We're talking about definitions and we're confusing our students, but every day we'll just show how a patient, same patient who comes into the ICU, and then when you put up these patients into different definitions, how will it influence the management decision? That is what is the whole essence. While we're managing these patients, how to fit in these definitions in the patient care and prognostication. So we'll start off with two cases, and Dr. Omkar will present the first case. So Dr. Omkar, please.
Very good evening. First of all, thank you to LTSI, Sareen sir, Rakhi ma'am, and Ashok sir for providing me with this platform to present and discuss this case. The first case that we'll be discussing is on extracorporeal therapies. I've shared my screen. I hope it is visible to all. So this is a case on extracorporeal therapies in ACLF. We'll just briefly discuss the case and then see what we did. So we had a patient, Mrs. RN, a 32-year-old female who's a known case of hypothyroidism on treatment, well controlled, who presented to us with complaints of jaundice of 45 days duration, which was painless, progressive, and non-cholestatic. About 20 days later, she developed abdominal distension, and 2 days prior to hospital presentation, she developed altered sensorium. She did not have any previous history of hospitalization prior to this hospitalization. So upon evaluation in the ER, the patient was found to be in grade 2 encephalopathy. Her vitals were significant for tachycardia with a heart rate of 110 beats per minute. Her lactates were 1.8, bicarb of 22. Her labs her labs at ILBS were significant for a hemoglobin of 10.2, platelets of 150, elevated INR of 1.8, and a bilirubin of 21. Her arterial ammonia at presentation was 196, had a baseline ARC of 10, grade 2, and a MELD of 25. After resuscitation and management in the ER, she was shifted to the HDU for further management. Her outside viral markers were negative. So now in this case, what should be our syndromic diagnosis? This patient has presented to us with jaundice followed by ascites and encephalopathy. So as per this Kyoto consensus, now would we be classifying this patient as an ACLF type A, type B, or would this patient be an ALF as per the ASLD criteria, which says that in patients with no history of liver disease, there is presence of liver injury with coagulopathy and onset of encephalopathy, or is this just a patient with an AIH flare? So just to give a brief summary, this has been adapted from the Kyoto Consensus, which was published in 2025 in Hepatology International. ACLF can be divided as ACLF type A and type B. So type A is what we classically see or what we classically define in the APASL criteria, where you have a patient who presents with jaundice followed by ascites and encephalopathy in a period of 4 weeks. In the APASL ACLF and in ACLF type A, the insult is predominantly a hepatic insult, and the patient may or may not have any extrahepatic organ failures. This is in contrast to ACLF type B, which is predominantly the Easel-Cliff definition of ACLF, which we classically see as the acute decompensations or the non-acute decompensations. So patients with cirrhosis who are presenting with progressive worsening of ascites or jaundice or any extrahepatic organ failure. So in our case, we had a diagnosis of ACLF, and the differentials that we kept at the time of presentation were AIH, and considering the age group, we had also kept Wilson's as a second differential, although it was less likely in this situation. Patient had organ dysfunction of brain, had grade 2 encephalopathy. So further, once this patient was shifted to the HDU, she was evaluated for the etiology, underwent a sepsis screen which was otherwise negative. The ascitic fluid was a high SARC low protein fluid, did not have any SBP. Viral markers which were repeated here at ILBS2 were negative. Her autoimmune panel was done, which was also negative, IgG of 10. Inflammatory panel was done, which was elevated, had an ESR of 56 and a CRP of 16.4. To rule out other etiologies, the patient underwent a serum ceruloplasmin and KF ring and an ultrasound Doppler, all of which were normal. So keeping a differential of autoimmune in mind, we calculated the simplified AIH score, which was 3, which was of possible AIH, and the international AIH group score of 4. So in this situation now, with this background and this differential and the labs that we have, what could be the next possible step? Should this patient be managed, be given standard medical management and be assessed for liver transplant? Should we take up the patient for a transjugular biopsy and then go ahead with steroids? Should we upfront go for a plex, dynamic assessment and then liver transplant, or upfront steroids? So as the treating team, now what we did was we monitored the patient, we observed her till day 3. There was no improvement in the encephalopathy, persisted to be in grade 2. Bilirubin was almost static. From 21, it was down to 19.8, but pretty much static. But more importantly, had a worsening INR and persistence of encephalopathy. Patient was counseled regarding the need for liver transplant, did not have any donor, and was therefore planned for bridge therapies. So after this, on day 3, the patient has undergone PLEX, the first session of PLEX. Following PLEX, as expected, we found an improvement in the bilirubin and INR, which came down to 15 from 19, and INR came down to 1.9 from 2.5. But what is most remarkable is that this patient also had improvement in her encephalopathy. From grade 2, she had no encephalopathy. So the patient subsequently did undergo a second session of PLEX. Following improvement in general parameters, the patient was then shifted to the ward. In the ward, she underwent a third session of PLEX, but unfortunately had developed one episode of fever with a maximum temperature of 100 degrees Fahrenheit. So in this situation, a patient who's already undergone PLEX, was in the transplant window, did not have a donor, has undergone PLEX, has now developed fever. Uh, so the differentials that we had in mind were, first of all, definitely an infection, a flare of infection, or second was, uh, could this just be an inflammation? So we had also calculated the Surfasa score at this point because of lack of other scores that we had, and Surfasa score at this point was minus 2.7. We will discuss more regarding this further. So now in this situation, what do we do? Do we give this patient IV antibiotics considering this is a flare of an infection, and advise the patient for an urgent liver transplant? Or do we continue PLEX in this patient with a suspicion for inflammatory fever? So what we did was manage along the lines of both. We did escalate antibiotics in this patient to broad spectrum antibiotics, also initiated antifungals at this point, and also initiated hydrocortisone at 100 milligrams per day, considering sepsis driven inflammation. After the patient's fever had subsided, the patient underwent a fourth session of PLEX. At this point, again, as expected, we saw the bilirubin to be reducing from 12 to 11, and INR had come down to 1.7 from 1.8. It would also be significant to note that inflammatory parameters were also on the declining trend with PLEX. We had also calculated MELD scores, and MELD scores were declining with the treatment that we were giving. So this patient then was subsequently discharged after a total of 4 sessions of PLEX on 0.5 mg per kg of prednisolone along with diuretics and other supportive measures. As we can see, CRP had also come down to 7.3 at the time of discharge, INR was 1.5 and bilirubin of 10. So then this patient was followed up on OPD basis. This was 2 weeks later when this patient had presented to us. Patient still had jaundice with a bilirubin of 7 with transaminitis, AST, ALT in the range of 60 and 15 and an INR of 1.7. CRP, which was previously 7.3, had come down to 4.2. She was continued on low dose steroids, but at this point, she had improvement in ascites, she had improvement in a general sense of well being, and did not have any further episodes of encephalopathy. When she has presented to us very recently, 2 days back, that is 3 months since her discharge, she has a bilirubin of 1.7, mild transaminitis with AST of 50, ALT of 27, INR of 1.3. At this point, she's undergone a fibroscan which has shown an LSM of 27. MELD at this time is 12. So this patient has been advised for a liver biopsy for confirmation of the diagnosis. But what is interesting and important to note that as per definition, this patient has had reversibility of ACLF, which is defined by um, bilirubin coming down to less than 5, coagulopathy INR being less than 1.5, with or without the presence of ascites. So when we look at reversibility in ACLF, as we know, as per APASL ACLF, these patients may be known or diagnosed or undiagnosed cases of chronic liver disease who have an acute hepatic insult, following which they develop jaundice and ascites. So in these patients, since this is an acute hepatic insult, it is very inflammation driven. The hepatic reserve in these patients is high. Because the hepatic reserve in these patients is high, and if we give an etiological management to these patients, such as alcohol abstinence in term, if the patient is presented with severe alcoholic hepatitis, management of hepatitis C with antivirals, or in our case, giving immunosuppression for autoimmune, we do see a reversal of ACLF where the bilirubin goes down to less than 5, INR comes down to less than 1.5 with mobilization of ascites. In case of reversal of ACLF, the hepatic reserve does improve. This is in contrast to patients with who develop acute decompensations and non-acute decompensations, who initially, in general, have very poor hepatic reserves. So this was a paper which was published recently in 2025 in Transplant International, and this speaks to us about the transplant windows that we have for patients of ACLF. So more often than not, we do have patients who present to us and they do not and they do have a donor, but upon presentation initially they are non-transplantable. We give them, we manage them medically or with bridge therapies in order to make them eligible for transplant. As we can see in our case, if you focus on figure number C, we had a patient who has presented to us in grade 2 NCAF with a diagnosis which was unclear, although in our case did not have a donor option, was initially non-transplantable. We patient had undergone 3 sessions of Plex, but then and was in a transplant window, but of course did not have a donor, but then developed complications. The complications in this case being fever. So in our case, this was more of an sepsis-driven inflammation, because of which we were able to control it with antibiotics and hydrocortisone, and therefore she managed to come into the second transplant window. But more often than not, we may not have patients who reach this second window. Secondly, as we can see and as we know, that patients who are transplanted within the first transplant window tend to do much better in the long term as compared to those in the second transplant window. So with this, we have a few discussion points which are important to note. And the discussion points in this from this would be the reversibility of ACLF, the role of etiologies, the plex utilization of plex in ACLF, the timing, frequency, and stopping rules, and the scores for response assessment and transplant. Sareen sir, Rakhi ma'am.
Yeah,
Rakhi, please.
sir has joined. Yeah, sir, please your comments on this.
Well, I'll be discussing this later, so I
Okay,
would
sir.
request you to go ahead.
Okay, sir. So, what we wanted to discuss and bring out points in this patient is when we are putting these patients on extracorporeal therapies, the first big decision is whether to go for extracorporeal therapy or not, because there is also a potential for reversibility of ACLF. So, this is one big challenge for all of us as clinicians, how to not delay the transplant and also do not avoid a chance of the patient for spontaneous survival. The big problem with us and with the surgeons, which we then have a difficulty in such patients, is the complications, obviously, of the extracorporeal therapies. And then because we have corrected all the parameters which were of prognostic implication. So then how do we assess? Because as of now, we have no scores when the patients have been subjected to these extracorporeal therapies. How do we assess the clinical response and how frequently we should be doing these, and when should we stop and we should say that the patient is not better? So we can have comments from other centers. Dr. Naveen, if you would like to comment.
No, I was just thinking, shall we do this at the end of the whole thing?
Okay,
Like,
sure,
it'll
sure.
be good because
Yeah,
both
yeah.
the
Then
cases will be there.
both the cases will be, and
Yes,
after
yes.
sir's talk, maybe.
Yeah. Yeah, that's
Okay,
better. Yeah.
okay, okay.
Good.
Take it. Okay, good.
Thank you. I'll now request Dr. Jaifrin to please present the second case.
First of all, good evening, everyone. I want to thank LTSI for giving me an opportunity to present in this platform. I will also like to thank Professor Shivkumar Sarin sir, Dr. Aki ma'am, and Dr. Ashok sir for this opportunity. I would like to go on our case, which had recently presented to us in ILBS. Patient was a 42-year-old male who had a private job as an occupation. He was a chronic ethanol consumer with consumption of 60 to 80 gram of ethanol per day for the last 15 years, with last presentation being 15 days back prior to presentation. He was brought to ILBS by the relatives with a history of worsening abdomen distension for the last 1 week, history of altered behavior for the last 2 days, and breathlessness for 1 day. He was known case of cirrhosis of liver, ethanol related, and he was decompensated in form of ascites and was on diuretics. He had none comorbidities and there were none surgical or family history which was significant. Prior to coming to ILBS, in view of patient's altered sensoria and breathlessness, he was taken to a local center where the patient was in a grade 4 encephalopathy and patient had a cardiac arrest. There, the patient was given a CPR for 5 minutes. There was a reversal of spontaneous circulation. Patient underwent an endotracheal intubation and then was referred to ILBS for further evaluation. When the patient presented to us first in the emergency department, patient was on a mechanical ventilator with a tachycardia, heart rate of 110, BP on the lower side 96 by 62, respirator 24 per minute with a PF ratio of 175. General examination, patient had a bilateral pedal edema was there for the patient. Abdomen examination, patient had a tense ascites along with a fluid thrill, and also there were reduced bowel sounds which were heard. Respiratory system examination, there were bilateral diffuse crepitations which are heard in both the lung fields. Central nervous system examination, the bilateral pupils were 2 mm. They were sluggishly reacting to light and bilateral plantars were equivocal. Cardiovascular system examination, the heart sounds were normal and there was no murmur which was heard. So at this time in the emergency department, preliminary diagnosis was made of portal hypertension, non-bleeder with a grade 2 varices and a mild PHG. Chronic liver disease, ethanol related, recidivism present with last intake being 15 days back and decompensated from ascites. So the current issues, what were thought in the emergency department was the patient is having an encephalopathy. The differentials for encephalopathy which were considered was whether it is a metabolic versus sepsis related or hypoxic in view of a recent cardiac arrest. The cause for shock which was considered was whether it was a cardiogenic versus a septic. Again, both because the patient had a history of breathlessness and altered sensorium, recent cardiac arrest. The focus of sepsis considered was aspiration pneumonia and in view of recent worsening of his abdomen distension and his spontaneous bacterial peritonitis and a status post cardiac arrest. So investigations which were done initially showed a pH of 7.3 with a bicarb of 17, which is an uncompensated metabolic acidosis. Blood parameters which were done showed hemoglobin of 7.4 with a serum creatinine of 2.9, baseline creatinine of 0.8 for the patient. His INR was 1.9 with the baseline INR being 1.4 with an ammonia of 256. LFT done prior was 1.2. Current LFT was 3.3 with the AST/LT of 46 and 20 and low albumin 2.5. Viral markers were negative. Ascitic fluid analysis done showed SBP. It was a high SARC, low protein ascites, and ADA was 4. Echo done showed an ejection fraction of 58%. At this time, there was no regional wall motion abnormality and RA pressure was 3. X-ray done showed infiltrates in the left lower lobe and also X-ray abdomen done showed dilated bowel lobes. So subsequent screening, sepsis screening was done for a patient. And at this time, the PCT came as 4.5. The urine routine showed leukocytes 1 to 2. We had done a multiplex PCR with group Klebsiella pneumonia. Blood culture and urine culture didn't show any growth. So now when we consider our patient, so does our patient fulfill the ACLF criteria? So when we look into the APASL definition, no, it definitely doesn't fit in. When we look into the ECL definition, yes, our patient fulfills the ACLF criteria. So when we look into our patient based upon the ECL ACLF criteria, patient had organ dysfunction in form of a coagulation, organ failure in form of cerebral, circulation, renal, and respiratory. Issues were again shock, septic plus cardiogenic. focus of sepsis being aspiration pneumonia and a spontaneous bacterial peritonitis. Gut failure, uncompensated metabolic acidosis. So at the time of admission, patient had a MELD of 28, CTP of 14C, and a CLIF-C ACLF score of 50. So when we look into a patient, an important thing comes up is why does definition matter? So as we know, acute on chronic liver failure is associated with a high risk of morbidity and mortality. Recently, there have been a concept of reversibility, which has come, as Dr. Omkar has mentioned. And patients with ACLF are sick patients, and in which there's a golden window for a liver transplant. Because if the patient has a worsening, the time frame of getting a transplant is very narrow. So when we look into the organ failure based upon the different societies, what we see is our patient had an organ failure from brain, circulation, respiratory, and renal, according to the ESL cliff. When we look into the ASLD definition, our patient had a brain, circulatory, and respiratory failure, while this circulatory, respiratory, renal are not defined in APASL. So now when we look, is there a need for defining organ failures in patients with cirrhosis? So there was recently a consensus statement published in gastroenterology by Professor Jasmohan Bajaj sir, which says different INR bilirubin cutoffs. It has uh, at our patient, when we look into it, our patient had a possible liver failure here because the INR was more than 1.5 and bilirubin was more than 3, with bilirubin being less than 7.5 being a cutoff. When we look into the new things which this organ failure consensus statement has brought up, here the concept is of immune system dysfunction and failure. So our patient here falls into the immune failure because the patient had a focus of infection and patient had a septic shock. When we look into the gastrointestinal system, our patient again had a GI failure because patient had to be given initially, cannot be given initially artifacts. So when we look into our patient, which is based upon the new criteria for the organ failures and cirrhosis, our patient has a possible liver failure with organ failures in form of brain, renal, gastrointestinal, and immune with a moderate ARDS and shock. And the issues which were earlier discussed like encephalopathy, shock, sepsis, and a status post cardiac arrest. So when we look into the course of a patient after coming to ILBS, the patient was hospitalized, was admitted to the LICU. Patient was initiated on a broad spectrum antibiotics. Uh, After 48 hours, we had done a repeat ascitic fluid analysis, which showed our response. At this time, the patient's vasopressors were being tapered, and by the end of 48 hours, the vasopressors were stopped. The gut paralysis, which was there, the gut paralysis also improved. Day 3, we had started on a weaning trial, and the patient I got extubated. When we look into the laboratory parameters of a patient course of hospitalization, what is significant is the patient came with a high creatinine. MELD was 28 at admission. At the time of extubation, which was day 3, the patient's MELD had come down to 14. Creatinine was almost normalized. And at the time of discharge, patient's MELD had come down to 15 with a normal creatinine, INR being 1.5 and bilirubin being 2.6. So in LICU, when the patient was there, the patient was clinically improving. So our discussion is what is the next step in the management of this patient? Should we continue with the standard medical management? Should we evaluate this patient for a liver transplant and donor evaluation should be done? Or should we just continue with the wait and watch approach? So at this time, we simultaneously involved our the transplant workup for a patient. So at the time of a discharge, our patient's MELD was 15. Patient was initiated on diuretics, and the donor was there in the family, and the patient's LT donor evaluation was initiated. So the discussion is this a true reversal because patient's creatinine became normalized, ascites is improved, and whether this patient was a candidate for a liver transplant at admission because MELD was 28, even though over the course of hospitalization before discharge, his MELD became 15. And should time be given in such patients before considering for liver transplant to control the acute precipitant such as sepsis? Thank you. Now I'll request Dr. Rakhi ma'am to give a.
No, we will have the discussion at the end, so we
Okay.
can have
Yeah,
Dr. Navi.
request sir to
Yeah,
share
Serene
his
sir.
slides. Yeah.
Thank you all for allowing us to join. And thanks Ashok and Rakhi and Omkar and Jaifrin. They have covered most of the things what I would like to say, but I just want to focus on few areas with no conflict of interest. This is the data of 2024, which is now about 12,000, is to show you and apprise you that the acute insult as per a parcel ARC database is alcohol, and the chronic insult also remains as alcohol. I'll try and discuss some fine points in terminology. So, this is the way we started in 2004, that a patient who has got an acute insult of ethanol, Hep B, or superadded viruses, autoimmune, Dilly Wilson's. In a patient who has underlying CLD, market CLD is stage 3 or 4 fibrosis or has cirrhosis. But I would also say CLD should include F1, F2, and there is huge data with us now that even F1, F2 matter. You define the chronic liver disease either by biopsy if endoscopy does not show any varices. This is the initial concept, and the liver failure at that time was defined based on the Lancet paper of 1980 that anybody who has got a bilirubin above 5 is severe alcoholic hepatitis. And also our own original 200 patients, those which showed from multiple centers that those who had jaundice and coagulopathy and ascites due to acute portal hypertension will have a poor outcome. And there is a potential from beginning of reversibility. So ACLF was acute insult in a chronic liver disease presenting as an acute liver failure or a liver failure. At the same time, the groups, all of them were with us, but subsequently in next 2009 to 2013, they decided to undertake a study in the West, where liver failure in their patients, about 1300 or so, was only seen in 14%, lung failure, kidney failure, coagulation failure, or multi-organ failures were seen in a large number of patients. Make it that they took AKI above 1.5 to 1.9. So there were two definitions which were running and dividing the world. One where hepatic insult, acute with jaundice, coagulopathy within 4 weeks. Also has acute portal hypertension manifested as ascites or HE due to liver failure with high 28-day mortality, while the Cliff Easel canonic definition was a condition within 4 to 12 weeks of jaundice or an inciting event. It can be anything, sepsis, bacterial, resulting in hepatic decompensation, failure of two or more extra hepatic organs with high mortality in previously decompensated or compensated cirrhosis. So, the effort of developing Kyoto Consensus with 162 people, and which was spearheaded by Ashok and the team, was published in 2025. As shown earlier by Omkar, I will very simply say type A is what this is: hepatic insult as the beginning. And this is a partial definition, this is Chinese definition, this is Japanese and ASLD. All of them mandatory hepatic failure. In type B is the group of Easel, Cliff, ASLD, I'll show you why, and Nexel, where you may have hepatic failure but any other 5 organ failures as shown below. So this type A includes this, while type B will include all these 6. But if you have to have a simple thing, with the patient आया है सर type A liver failure है, means hepatic failure है, or type B or hepatic failure. And this is a diagram which we wrote in hepatology, that the tale of two cities. And the tale is that first acute insult and the early detection is by the apostle definition, where you have at the beginning no SIRS or it develops to SIRS. And easel cliff, you start with extra hepatic organ failures. Any of these, liver failure may come, may not come. But this is a stage where, because of the organ failure, which are a result of sepsis or shock, will develop. This is where we were, and Kyoto Consensus tried to converge these into two simple types, hepatic or extrahepatic. Now comes an ASLD has one organ failure in addition to the liver. It can be anything, but it clearly 2024 definition says that hepatic insult and hepatic failure is mandatory. The Japanese definition is exactly like what apostle is. But I'm not here today to define whether this is good or that is good. It is simply to say there are two types. Now, the severity you can see by ARC score. Kosh has another score. Cliff C has another, as told by Jaifrin, or MELD score. So, one more time, I would like to say what is the ACLF ARC score. It has liver failure, jaundice, coagulopathy, encephalopathy. When we did that multiple regression analysis, lactate came. Nobody wanted to do lactate in 2017. Korean said without lactate ARC. But today, MELD lactate or lactate has become the cornerstone of liver failure scores. And one other organ we also included in ARC from the beginning was creatinine. And somehow this thing has come on my screen. I don't know how to remove. But the bilirubin, He, INR, lactate, creatinine. Now the beauty of this is the ARC score includes creatinine of less than 1. In fact, 0.7 should be considered normal creatinine. And it also includes patients who have pre-ACLF kind of thing, where INR may be just less than 1.5, but bilirubin certainly is high. ARC grades 1, 2, 3, you fully well know. And the beauty of this ARC score, which is now again coming up in some Nature papers, is to say that people who have got a score of less than 10, and Raki beautifully showed those who had an ARC score of less than 10 will respond to steroids in alcoholic hepatitis. Above 10 will not respond and will die. And if you have an ARC score of less than 10, then there is an increase of 1 unit. The mortality increases by 5.2. But suppose you were on ARC 9 and you have jumped to ARC 11. From ARC 11, any 1 unit increase will have 20% more mortality within 7 days. So we know that we need to hold hands with the transplant team. And this is the score. You all are familiar, the Cliff ACLF scores. The only thing I want to show here, the challenges in this are that patients are already having circulatory dysfunctions or have respiratory dysfunctions. And in fact, people may have bilirubin, which may be 1 or 2, and they still will get point. So there are several challenges with Cliff score, but these are developed for ICU patients, and they are developed in an intensive care transplant team. I'll now briefly discuss what is new in Kyoto, organ dysfunction and failure. I would like you to take a picture and remember this. This has developed with great effort. So one is liver failure, bilirubin, INR and He, and then extrahepatic organ dysfunction and organ failure. So these are two separate things. Dysfunction cerebral, which has been defined not as cerebral dysfunction but cognitive dysfunction. Then you have cognitive dysfunction of grade 3 and 4 as brain failure or cerebral failure. You are aware of respiration. These are dysfunctions and failures, circulation. So anything which is between 65 and 70 is dysfunction. If you require vasopressors to maintain 65, it is circulatory failure. And of course, kidney stage 2 or 3, which may require renal replacement therapy. Now, this is an important slide which has been developed very recently by us. Is the crux of managing ACLF is to prevent organ dysfunction, prevent dysfunction to go into failure, and try to reverse the organ failure. So you need caution. In fluids and albumin, please do not just go by IVC that I have to make IVC 20. He came with 14. It's good to have 16, 17. Don't take IVC too high. And albumin with great caution because the after effects of albumin may last for 24 hours and pulmonary edema may come. Avoid nephrotoxic antibiotics, very carefully choose them, antifungals and contrast agent. Don't do CTs left and right. Reduce abdominal pressure. Normal pressure, as you know, is less than 12 or so. Not anything. And ACLF ascites is generally has a pressure of 24 to 30. So try. Prevent MAP going below 65, but also remember don't load the heart with things so that don't let it go above 80. Avoid lactulose, unindicated correction of coagulopathy, and terlipressin usage to prevent afterload. I come to other concepts which were given in the Kyoto. The Kyoto consensus, you can directly show patient develops ACLF or this patient go into decompensated cirrhosis and ACLF. This is the path by Easel ASLD, while the path by Apostle and the Asians was this. Now, if you treat etiology for 12 months, this patient may have regression of cirrhosis or recompensation. This is the term for cirrhosis. For ACLF, the term is reversal. As Jaifrin said, reversal of ACLF is the term because it's a syndrome which is getting reversed. So reversal of ACLF is reversal of parameters used to define. That means bilirubin, ascites, or coagulopathy. The evidence was low, but recommendation by everybody was strong. If this occurs within 6 months, it is the reversal. But if it occurs within 3 months, it is early reversal. And reversal is the therapeutic goal because it can delist from LT. So I want you to remember difference between the recompensation versus reversal of a syndrome. Now index presentation can be ACLF again. So patients who has achieved reversal can have again ACLF. So here this patient had reversal of the syndrome, but he starts drinking or he stops antiviral and he gets ACLF again. So this time he may have the course of multi-organ failure or transplant or he may die. So index presentation every time he gets a repeat attack after reversal of the syndrome will be called ACLF again, and I hope you like this term. All subsequent episodes should be with the index. So it is ACLF again second time or third time, but manage it like ACLF. So this concept diagram was also given in the Kyoto consensus. Compared to a normal, the cirrhosis or the compensated advanced chronic liver disease, patients will have smaller hepatic reserve. In ACLF, it may rapidly shrink. When you have a reversal of the syndrome, maybe some of the liver regenerates or the toxins go away. On the other hand, recompensation of cirrhosis, you may have much better liver. So these patients actually are better off and they can also with treatment have regression. But you can have concepts of acute decompensation. Very briefly, I'll say ACLF again and non-acute decompensation. Acute decompensation as is a very confusing term. And acute decompensation versus ACLF were separated in the Kyoto consensus. AD is a distinct entity presenting within 12 weeks of a precipitating event. They do not believe jaundice as part of AD, the West, but the Kyoto consensus says jaundice is routine, should be accepted. The debate was what should be the level, but I think jaundice generally would be anything which is above 2 but maybe 3. Here is the debate: ascites or HE. ACLF is characterized by acute hepatic deterioration with multi-system organ failure. So AD is slow, it can be non-acute or it can be acute. ACLF is always severe, and now most people even easily is going to accept it, hopefully, acute hepatic deterioration with other organs involved. So what is new in Kyoto? A universal ACLF definition will include all aspects of this, type A or type B. Very briefly, in last one or two time left, is timing of liver transplant. Single line concept in Kyoto consensus, the core: convert non-transplant into transplantable. Otherwise, they're all futile. And of course, those who are transplantable, whether they can be done, managed without transplant or so. And this is just to give you that the unfavorable or futile, although we say that, but we will still try, especially those who have bled. We'll treat the sepsis, we'll improve the lungs. Lactate, yes, anything above 9, people generally will give up above 4, but I think you can manage these. The surgeons are so good. And 3 organ failures, very little chance of improvement. Therefore, we have to work. And pre-ICU frailty, but ACLF generally is not that frail. And this is the last slide. So this part is important. From day 0, when the patient has come, etiology is specific, maybe hepatitis B, drugs, single or dual antiviral, steroids, sepsis control, nutrition, and preventing organ failure. Remember this, very, very important. In this, ARC score above 10 or MELD above 30. Such a patient, if it comes, let's say 11, immediately consider counsel day 0 on transplant. While the workup is on, and if the patient with your management improves by day 4, then there is a chance he will improve by medical management. However, if by day 4 he worsens, then emergency transplant. Then extrahepatic organ failure as per EASL Cliff, you may take up for transplant if it is ready, or try to stabilize by plex or artificial liver support. If it is improving, emergency transplant. Not improving, maybe it is late. And if he has come with 4 or more organ failures or ARC above 13, I think patient will have little chance of survival. This is my last slide. So what Kyoto consensus the team across continents provided, and many of you were part, was to give first step of convergence. It is not easy. Now the next came up with ASLD took up, although they took many of their own ideas with 7.5 bilirubin rather than 5. But okay, the next step was ASLD. Then now the Beijing report of 2026 is likely to be circulated. EASL might do something in 26. But my suggestion, my request, humble request to all, and Sanjeev and others, Charles, and maybe all surgeons, Sonal, LTSI should collect data from India on LDLT in ACLF using both definitions if you like, but let us have data from the country which has largest number of liver transplants. Thank you for allowing me, and both the cases presented along with this or what Ashok says and Raki can be discussed. Thank you.
Thank you very much, sir, for a wonderful oversight of everything. Dr. Sanjeev is there. Please.
Yeah, I must immensely thank all the speakers. Sir, you have really, shown a great summary of the entire thing. And I like your last slide, the last line that we in India have all the patients. We are leading the definitions. Your work has been phenomenal. And certainly, the LTSI has a responsibility on the shoulders. We should definitely, like we are working on it, but we should really look into our own liver transplant data, understand futility. Because recently, have seen many patients which we are trying to do in a advanced ACLF 3 plus. Uh, the outcome is not so good. So we have to be more, like careful and select out futility versus non-futility. And I think we are trying to understand the LTSI database so that we can, have a multidisciplinary interaction and then, come to better conclusion. I think that's a great session, and I think I'll take the responsibility for that and pursue it, sir. Thank
We
you, sir.
start on October 1, Sanjeev.
So I
We
know, sir,
start
you give
October
normally,
1st, and you
normally.
have now 13 days. So no more this and that. LTSI's flagship program. You lead something has been made by Ashok and Mohammed, so that is there. They will provide you. Mohammed and Dinesh were there, but somewhere I don't know is Mohammed there or not. But 1st October we'll launch 2025. Okay.
Having worked with you for 25 to 30 years, sir, you normally give 7 days time. So it's 13 days this time.
Okay, my friend. Okay, go ahead.
Naveen and Raki, please, a discussion, please.
Yeah.
Yes, Dr. Akil, please.
So what we wanted to show and what Sir has nicely alluded to his in his talk. So the second case, which is like based on the Easel Cliff definition and where this APASL definition, we are not biased, but we are saying that we just want to show that how definitions make a lot of difference when we are selecting out patients for liver transplant. Both set of patients are sick, both meet different definitions of ACLF. So sepsis is one area, because if there is a sepsis related organ failure, the patient is very sick, but are they, from there should we start discussing about transplant, or should we be discussing previously with prevention of organ failures and organ dysfunctions? So that is how. And then the reversibility, even if this patient has resolution and is out from the ICU, will you not consider a transplant? So those two things were very important, that reversal of the syndrome based on the components. When we say APASL, the reversal is a complete reversal of the disease syndrome. But when we are talking about different definitions, again, reversibility also makes a difference, because the patient has still not reversed. We need to consider a liver transplant for such a patient. So those were the points of discussion to be brought out, that why definitions, because real life case scenarios, this is what we see.
I will, sorry to interrupt, Raki. What do
Yes.
you think the surgeons and others of the type A, type B? Those who favor this can say thumbs up, maybe show that we okay. Can you show this? Those who do not will not. If people are there, can you say, yeah, we agree with it or disagree? Can you show reactions?
I don't think I. There are a
Not
lot of
visible.
thumbs up, sir.
नहीं ये
Yeah,
तो मेरी तरफ से मुझे आता नहीं है.
That's yours. Okay, okay.
yeah. I tried my level best, Naveen. I got it fine.
Finally. Okay. So just to say that if you all feel this is a good definition or it will solve the way people are, dividing, are you okay with this definition? Others can give opinion or no? Time is less.
I think sir. I think it is better, like to it simplifies a lot of things. Otherwise it was very complicated. I think what we are learning over the period of time is that we are simplifying and putting them into broad categories so that it is easier for us to understand. I think that's what it is, because we had so many definitions and we were all confused what we are going to do next.
So now is this better, type A, type B?
Yes, yes, sir.
Okay, it's like HRS type 1, type 2,
Yeah.
something like this. Okay.
There's
Now
there's less of gray. There's less of gray zone with this, sir.
less of gray zone. So type B can include both type A. It can include that non-hepatic or hepatic insult, while type A will exclude this. Ashok, any comments? Where are you? And about the cases. Okay, now about Keshav. Abha has
What
something for
Dr. Abha is saying, yeah, we also said this patient that he should not go for a transplant. But our discussion was at the time where we were extubating, when we started managing this case. So obviously we are changing, and that's why we said now, because he's rapidly reversing, but many patients may not reverse. They just resolve the SBP. And this patient definitely showed a lot of complete reversal and possibly of alcohol related problems and acidosis secondary to which led to cardiac arrest. So this was a different case scenario, but what we wanted to highlight was a decompensated cirrhosis who gets better. Obviously, can still be considered once he's out from the ICU, during the ICU for an emergency transplant. So the definitions there may be a little,
Can we
uh, the
have
means the debate.
questions now from other people?
Yes, sir.
Yeah, please fire.
So maybe I can ask one question to Rakhi.
Yes,
See,
sir.
Yeah.
in my clinical practice, I've realized that when you have a decision to take a transplant or not, a cross-sectional imaging is extremely helpful. If you have an imaging which shows a shrunken liver versus a liver which is big, and so you can really immediately decide which one to go for transplant and where you can wait. So in both these cases, you have not really highlighted on that part. So what's your opinion on a cross-sectional imaging, a CT or MRI, whatever is possible, to
Yeah, of
understand
course.
the course?
Of course, whatever you said, imaging is very important in this particular case because, like we said, because the patient was in the ICU and subsequently was taken up to the ward, and the imaging was not performed for this patient. But obviously, before liver transplant, as a protocol in our center, we're doing a shrunken liver will definitely show a poor hepatic volume and reserve, and that again suggests. But again, so we look at the MEL scores and the synthetic functions of the liver
But
apart
you are
from.
right, Sanjeev. Small liver bad, large
Mm.
liver good.
Yeah, that's a teaching which you taught us long time
Yeah,
back.
large liver is good. There is liver.
Yeah.
Yeah. So
I think only one thing that we can also consider from this is that we are treating these patients. We know they may recompensate, but I think we should never lose that counseling to the patients that he may need a transplant at any
Transplant,
point of time.
yes. Yeah,
Because
donor
that idea to keep everything ready, and if things get better, it's always good.
yeah.
But if things are not getting better, and we need to have a timeline in our mind, because these people, if they get stuck, they're not going to get better. It is quick recovery or it is a delayed poor prognosis.
what is surgeon's opinion? Are there surgeons, some of them?
Looks
Because
like we have overtaken the LTSS.
They
surgeons
should.
who do they prefer a plasma
Which,
exchange,
yeah,
plex? Do they prefer because these were three questions Omkar has left. Plex and
there are
so
some questions in the
So we
chat box
had
Yeah, I
we
for
think
you.
there is a.
the discussion points were the plex regarding the timing, the number of sessions, and the stopping rules for plex.
yeah.
Another important point was discussing scores for assessing response of patients who are undergoing plex. So Surfasa is one such score that has been provided, but that is for steroids. We do not have any such scores for plasma exchange. So do we use MELT? Do we use ARC? Do we use a Surfasa score or any other scores? So that was also a point of discussion, sir.
So experience from Sanjeev or Charles on plasma exchange or
So
anyone else?
I think Charles is there. I'm sure he's has.
I think I am using his profile because I'm recording the meeting, sir.
Okay, okay. So, like I've seen that uh, Plex is an extremely useful thing, but sometimes if the patients are sick and there is a risk of sepsis, is it true, Raki, that it can like precipitate sepsis when you're using more two or more sessions?
So we have seen this, and that if the patient has rebound increase after the second or third session at the most, we have to consider stopping because then you get adverse events, and we should definitely stop and consider liver transplant for those patients, not do any further sessions.
So there's a
I
question
think
from one
first
of my
and
colleagues,
second are
sir.
done well. Third creates challenges.
Right, sir. So one of my fellows had a question. What is the current golden window you would say after all the developments and Kyoto consensus? So as a take-home message, his question is, what is the current golden window in ACLF?
Ashok. Where is Ashok? He is the creator of the window. Where is he? Ashok, what is the current golden window? Not the gold, the golden window. Ashok is not around.
I think
Well, I would try, and Rakhi can supplement. We still would say 7 days. I
Sir.
think it is the best time. But you should start stirring by day 2, day 3 also. If there is a galloping rise of bilirubin of more than 5 per day, or an INR of more than zero point 0.5 every day, today is 2, tomorrow is 2.5. So I would say rule of 5, 5 in bilirubin, zero point 0.5 in INR every day is not a good sign. Steroids won't work. Maybe we should start thinking very rapidly.
Sir, there is one more question. Your experience in using bilirubin filters or hepatotoxin filters in ACLF patient management?
Well, Rakhi could answer it better. Uh,
So, as of now, what we have seen is if we have to use adsorbents as against plasmapheresis for the sicker set of patients where you have challenges with the lung, kidneys, they are better tolerated therapies. Any form of adsorption therapy, so any form of CRRT or adding a bilirubin adsorption therapy, that is better and safer in a sicker set of patients. Plex, and that is where the golden window concept, I would say, that will be different from different severity of sickness of patients. For the ICU patients, maybe just day 3 you have to consider your window and of opportunities. And for these less sick patients, yes, there is where we can use Plex and revert and prevent a liver transplant. So that is where we
for
can actually use Plex.
filters, there is a paper from ILBS, just to give you, where standard treatment vis-a-vis the plasma exchange or the uh, dual filters were used, bilirubin and bile acids. So there is a significant advantage of using bile acid and bilirubin filters to decrease organ failure incidence, although mortality did not change, but reduction in the sepsis, organ failure was better with filters. I think it is the worst is the bile acid, and if you can remove bile acids, either by plasma or by this, it works. I think we have run over our time. Is that okay?
Yes, sir. We are almost. One last question is there from Dr. Abha.
Ma'ams.
The-
Yeah, can I answer this question?
Yes,
So,
please, please.
yeah,
The first
because
question was given steroids.
yes.
Was it as
So
a part
the
of the PLEX
concept of
protocol?
this is
Yes.
actually the CMC Valor has been the originator to propose. And obviously, all protocols, if you see for plasma exchange, which is done for immune mediated diseases. So even the Apache trial had a IVIG because Plex can just do the removal. The disease or the immune system also has to be managed. So a protocol of adding a steroid in low dose and not doing repeated Plex will also be, and we have seen in our experience, it works better as compared to doing repeated sessions of Plex.
Right.
I think Dr. Raki, would you agree that we do a couple of sessions of Plex and give a small dose steroid?
Small dose
Would be only,
steroids to
yeah,
handle the
maybe.
immune storm and
Yes,
then
yes,
wean the
yes.
patient
So,
off, and it works
yes,
well in the
yes,
less sick alcohol and all the
yes,
other
yes.
inflammatory conditions. Yes.
I would say that actually is okay. So if not any more, I think great discussion, and thanks, sir, for joining and giving us the overview of everything and the Kyoto and the A and B. I think we should be talking about these things more simplified now. Thanks, Dr. Rakhi. Thanks, Dr. Ashok and the ILBS team for agreeing to do this, and Dr. Saigal for initiating, and Charles and Dr. Abhideep for getting this masterclass sorted out. Thank you. Thanks a lot.
Thank you, Sarin,
Thank you.
sir, for
Thank you.
your time, sir. And behalf of LTSI, truly grateful to you and the entire team. And thank you very much, sir.
Thank you, sir. Thank you, sir.
Thank
Thanks,
Thank you, sir.
everyone,
Thank you.
you.
for allowing us to be with you. Thank you.
Thank you.
Thank you.
Thank you.